There we go. I have some disclosures. None of them are relevant to this talk. I looked at some of the literature on inflatable penile prostheses, and there's similar risks that we see in orthopedics. For example, smoking status. People tell me they quit. We verify it. I get a cotinine level in the pre-op clinic. If they don't pass, they don't get their joint replacement. HIV, Staphylococcus nasal carriage, and in our specialty, this is the same. Now, how is staph from your nose getting to your joint? That's another talk. But if you're interested, look up the Trojan horse mechanism and go down that rabbit hole. Revision surgery is same. Hemoglobin A1C, some orthopedists are using 8, but 8.5 is similar. Spinal cord injury, chlorhexidine scrub, antibiotic impregnated coated implants decrease risk. And again, this nasal decolonization. If you aren't doing it, it's 5 days of mupirocin ointment right before surgery. They also make a betadine swab that in pre-op, you can ask your ortho colleagues, the nurses, I have them do both, swab the patient's nose at the time they're in pre-op. Our institution is a specialty hospital that was purchased by our hospital partner in 2015. The rooms are non-laminar flow. Private practice and UT medical school staff work there. It historically, as a private-owned orthopedic hospital, it had a 2.5% infection rate. I considered that an emergency and made it a top priority and formed a team of 6. The chief of nursing, the CEO of the hospital met. We were meeting monthly, and I hate meetings, but that wasn't enough. So we went to weekly meetings to get pharmacy and all the changes on board, things we needed to do. And then this is important. When we meet at hospitals, and I had my entire career, and talk about infection, it was just us surgeons. I had a meeting with the entire OR staff, including the orderlies, and I'm going to show you part of the talk that I gave them. I discussed the historical data, explained the magnitude of prosthetic joint infection, talked about a culture change where everyone could say to the surgeon, hey, I think your gown touched the table over there, and not be afraid to do it. Gave a version of a talk I'm about to share with you, and then I asked for suggestions, and this is powerful, and I'll show you in a minute what even the orderly said that was game-changing, and we didn't realize when you were not in the room what's going on. I showed them 4.5 to 5% of all joints fail in the first decade. Within the first year, it's 1 to 2%, and then it's that hematogenous spread or the Trojan horse mechanism where neutrophils are taking bacteria to our implants. I showed them it had high morbidity, and I wanted to shock them with horrific images of what an infection does that they don't see. They're just in the OR every day. They don't get to see this stuff routinely. And then I showed them that infection kills. It's an independent predictor of mortality, and those of us with gray hair that might need a joint replacement, pay attention to this. It has a 400% increased risk of 1-year mortality compared to an aseptic revision. And 1/4 of patients treated for prosthetic joint infection in our field are dead within 5 years. So this graph, I showed data from the American Cancer Society that if you got testicular cancer, Hodgkin's lymphoma, melanoma, and breast cancer, you'd have a better 5-year survival rate than if you got a periprosthetic joint infection. So some of the recommendations we had at that time were showering before surgery. I get my patients chlorhexidine gluconate scrub, and 48 hours before, from the neck down, they take a scrub with it. 24 hours before, the morning of surgery. When they get to the hospital, they use chlorhexidine gluconate wipes, and your hospital has them with your orthopedist. One study in our literature decreased prosthetic joint infection 6.3-fold. Alcohol in the surgical site preparation, not just a betadine or chlorhexidine scrub. If it's not feasible for y'all, I also take rubbing alcohol before we prep, and we rub our skin, and then we do our prep. Supplement oxygen and normothermia. Prophylactic antibiotics. We had surgeons just giving 1 gram of Ancef to everybody. I put pharmacy in charge of it. They weight base it. Some giant people get 3 grams, others get 2, and it took it off the surgeons, so we got appropriate antibiotics every time. Laminar flow is not necessary in our literature, but positive pressure and reducing particulates. Adhesive draping is not necessary, but these studies didn't use antibacterial agents, so I'm a big believer in adhesive draping, never touching skin if I can avoid it. And we use wound irrigation with a certain concentration of iodine, and it turns out most of the iodine in our hospital wasn't sterile. The Mayo Clinic actually found Pseudomonas in their iodine. We do have a product in orthopedics, you can again ask your colleagues at your hospital, where it is sterile and it's in the right concentration. You don't have to mix it. And then we use negative pressure wound therapy in our high-risk patients. This is interesting. Are light handles a source of contamination? Yes. And some studies show almost 15% of them are contaminated in routine total hip and total knees. And just placing the light handles on, if you've got fluorescent particles in the studies, and then moving the lights around, you get unsterile particles all over your field. This is where the orderly came to me after the talk and said, look, I don't want to get anybody in trouble, but the person every morning that's supposed to wipe down the top of the lights doesn't always do it. And I went, holy mackerel. Surgeons advise to minimize contact, change gloves. I wear a headlight. We put on our handles before we drape so no particles are on top of our drapes. What type of dressing has the lowest infection rate? For us, it's either occlusive and/or has silver impregnated antimicrobial in it. Should suction chips be changed during surgery? This Scandinavian study showed that in heart surgery, they used 2 sucker tips. And at 1 hour, they cut off the tips and cultured them. 80%, one or both of them, were positive for cultures. Now, how is that possible? We have particles in our ORs that are not sterile, and the suction tips are sucking for an hour, and the particles are adhering. So we have an alarm in our OR. At 1 hour, we pull off the sucker tip and get a new sucker tip placed. This is my gloves. On the far left, I could see this on the indicator, what looked like liquid at the end of cases. And I'm like, this has got to be perspiration. And we wear 2 gloves because of the sharp things. And you can see it is. But my question is that sterile perspiration? I didn't think so. So I did a literature dive, found this study where they put particles on people's hands and had them do things. And you could see particles escape onto the gowns. And their statement in the paper said the junction of the gown and glove interface in our modern spacesuits is not sterile, and in fact should be considered an area of particular vulnerability in terms of contamination. So we did some research at our facility, and we wanted to see it was potentially contaminated air escaping the gown and glove interface, and were these particles sterile because we'd scrubbed our hands, or are they unsterile? And whether you could do things to help prevent this. So if you look at the bottom left, we had our engineers get a spherical mirror, and you can see there's a diaphragm effect of your glove in your palm, and it's literally pumping air out onto your sleeves. So on the right, we tried different things, and the things in the middle don't do, but if you just get sterile tape and put it around the gown glove interface, you can see here compared to no tape, dramatic reduction in colony forming units and contamination. So we tape our gloves. This study was another one of my fellows we did looking at where is the contamination occurring in our OR. So we put cultures out, culture plates, and it's only 3% at the OR table. The highest is our instrument table. 33% of the contamination is occurring there. So we did a study where we put tape on the floor 1 foot away from the table and 3 feet away, and just had someone walk by an empty OR and that table slowly every 5 minutes for an hour. And if you look, compared to the control group, you have 5 times contamination if you're 1 foot away from the OR table, just slowly walking by. So if you can keep people at least 3 feet away from the OR table, the circulating nurse, the salesperson that's in the room, you can cut the contamination in half. And this is, if you look on the bottom left, people are the greatest source of contamination in OR. 10,000 bacteria-laden particles a minute are floating because they're heated. They're floating off of people in the OR. This was another one of my studies Dr. Maldonado did, and we had 26 cases. None of them got infected, but he did 962 microbial surface cultures. At the start of the case, in the middle of the case, when is the most contamination occurring? And we also had a particle counter in the room. And what's interesting, and it would apply, I suspect, to your field, the implantation phase was the highest amount of particles in the room and contamination on everything. So you've got sales reps opening packages, people leaning over the instrument table, dumping things on it, and that is something that we've all got to stop and take a look at. Surgeon gloves had the most contamination, which shocked me. And so, but there was no correlation in our study with door openings, but if you look at the bottom left, that red circle, the magic number in our OR, if you get 8 people in there, or there's myself, a fellow, a PA, the scrub tech, that's 4, anesthesiast 5, circulating nurse 6, sales rep 7, you get 1 more person in the room and the particle count goes dramatically up in our ORs. We wear these spacesuits, so this probably doesn't apply, but we tested whether just putting a vest over the open gown that we have in the back made a difference. It cuts the number of particles in our little decontamination chamber. The vest is $5. $5 to cover up the back of your gown. And certainly some obese people, it gapes open, and this is probably not a bad thing for $5. Put a vest on. This study is really interesting. We looked at the non-scrubbed staff apparel in our OR. You look on the left, those are fresh out of the scrub dispenser, and we put somebody in a bunny suit, if you will, and had them cover their hands, and then we put them in an isolation chamber, and it was significant. Then we simulated in our ORs. We had 4 people, the anesthesiologist, the circulating nurse, the salesperson, and then 1 other person coming in and out, and we looked at culture plates and particles in the rooms, whether they wore the standard OR gear or this bunny suit with gloves on their hands. This shocked us. 78%, almost an 80% reduction in the positive culture dishes around our room and particles in the room. And if you look at the intel, we've got people dressed better making microchips than in our ORs walking around, and that should change. Now, I haven't made this change in our OR because that bunny suit is one piece and zips up the front. It's kind of hot, and if the female nurses want to go to the bathroom, they got to like take it off to be able to go to the bathroom. So our lab, we're looking at what can we do, a different type of OR apparel for our non-scrub people in the OR. For us, local antibiotic powder, if you look at the spine literature, 13% to 0%, 11% to 0%. If we add topical antibiotics in our wounds and spine, dramatic difference. Total hips, just read the bottom, deep rate, 0.8%. This individual, Crawford, took it down to 0.09%, and the only thing he did was add topical vancomycin powder. May not apply to your specialty, but this might. I use an irrigation solution. If you give IV vancomycin, the most concentration you can get is 5 micrograms per cc in your tissue. It's transient, affected by tourniquet. I have 1,000 micrograms per cc in a spray bottle with polymyxin for gram-negative coverage, and we just spray the wound. We've got to irrigate saw blades anyway to keep them cool, so I'm just spewing antibiotics everywhere around it, and our OR calls it bug spray. So at our institution, we had a 2.5% or 2.4% historical infection rate. In February 2016, we started some of these protocols. Triple gloving when draping, these vests that cover the back of the gown. Only the surgeon touches the implant, and only after he or she has put on new gloves. Automatic conversion to weight-based antibiotic doses. This is that standardized betadine soak. And then we use either the powder or bug spray and the nasal decolonization. What did this do to the OR? And the talk to the folks I'll show you in a minute. Let me put all these on, and if you want to take a photo, because it's long, we changed how we put on light handles, we changed our suction tips, we limit traffic in the room, et cetera, et cetera. What did that do? This is the graph of all the infections we were having. And in February 2016, they went to 0. For 9 months, this graph goes on to 0. Now, we periodically are having infections now, and I'll show you the impact of that. But it wasn't subtle, it was dramatic. I don't know which thing did it, because we didn't change one thing. We changed the culture, and we changed a lot of things. So in summary, changes require the entire OR team. In our facility, by taking, hypothetically, 2,000 joints a year, going from 2.4%, we would have expected over 6 years 288 infections. We're averaging 0.4 with all the doctors there. Mine is lower, and we would have 48 infections. So we prevented, in 6 years, 240 infections. If the average cost to treat a periprosthetic joint infection is $116,000, we saved $28 million. And we saved 60 lives if a quarter of them would have been dead in 5 years. Now I'm going to tell you the bad news. 2 weeks ago, I had my fellow climb up on a chair. Hey, would you check the top of the light booms? It's been a few years. This is what he did. So to keep we were patting ourselves on the back, but constant vigilance is necessary and accountability in the whole team. And I say extreme ownership. Since 8 years ago, we've got new people, new orderlies, new people doing the terminal cleaning. I need to give the talk again. Part of this is my fault. I haven't told the people how important or showed them this talk in a while, so I recently did. Perfection is not attainable, but if we chase perfection, we can catch excellence. Thank you.